Ma'am, we are live now, ma'am.
Yeah. So, good evening, everybody. At the outset, on behalf of IAG, I would like to welcome you all to the third episode of the Scope and the Choker series. So, this is a monthly webinar on certain specified aspect of a particular pathology will be discussed by eminent faculty in the particular field. So, today our focus of discussion would be on deep infiltrating endometriosis. So, deep infiltrating endometriosis, as we all know, is a very aggressive of the three phenotypes of endometriosis, which mainly affects the anatomy and also affects the functional characteristics of that particular organ. So, if you see, in fact, the deep infiltrating endometriosis, the management has been widely debated, and also we still do not know, in spite of all the advances and also research which has been done, as to which would be the right type of management of this particular disease. And also, if you see, the definition also is not very clear. So earlier it was thought that when the peritoneal involvement was more than 5 millimeters, we would call it as deep infiltrating endometriosis. But if you see in the recent Cochrane, it says that it doesn't matter even if it is not involving the depth of 5 millimeter, just the involvement of the fibrous and the muscular tissues of the particular organ, if it is involved, then you can call them as deep infiltrating endometriosis. So the management, in fact, in this particular condition is really challenging. Though we have various modalities like the medical and the surgical, the medical is the initial choice of treatment by everybody. But then there are certain times when we need to really resort to surgery because of the various factors involved with medical management, like the side effects and also the severity of the disease, wherein the medical management, the pharmaceutical agents do not penetrate the fibrous tissue. In such a case scenario, we have to resort to surgical management. But in this, the right technique and all the and also the expertise of the surgeon is very vital in managing these challenging situations. To see this, how we are going to manage these challenging situations in all the three particular scenarios, we have our eminent faculty today here. We have Dr. Sanjay Patel sir, we have Dr. Jay Mehta, and also Devan Jogal for to cover various aspects of this deep infiltrating endometriosis. To start with, I would also we'll also have two young endoscopic surgeons, Dr. Ankur and also Dr. Balaji. And our chairpersons are going to be Dr. Rekha Kurian, Dr. Sujal Munshi, and also Dr. Nisha Kapoor. So I would like to now welcome our President of IAG, Dr. Kalyan Bhamati, to deliver the welcome address, please.
Uh, Thank you, everybody, for joining. It
Before
is
that,
nice.
excuse me, let me just take a moment to introduce our very vibrant and versatile president of IAGE.
It's
So,
okay, Dr. Mala. It's okay.
okay,
Thank
right.
you.
One
Thank
is
you so much for joining in large numbers. And this is going to be a really nice webinar where stalwarts from Laparoscopy Association and as well as those who are doing a lot of endometriosis work are going to demystify deep infiltrating endometriosis. We have none other than Dr.
I think he
think got
talked by
disconnected.
Dr. Sanjay Mehta. Hello.
Hello,
yeah.
yes. Connect in between your voice
I think you
Yeah,
disconnect.
so sorry. Dr. Sanjay Mehta, sir, who is going to talk on peritonectomy. Dr. Jay Mehta on bowel endometriosis, and Dr. Deven on urinary tract endometriosis. So, uh, I welcome everybody for this feast, which is been arranged by IAG and our coordinator, Dr. Malaraj. I'm really thankful to Dr. Sujal Munshi, Dr. Sejal Naik, and Dr. Malaraj for taking this initiative on Trokar and Scope series. Thank you so much for this joining this webinar. Thank you all to Dr. Mala.
Yeah. Thank you so much, sir. So, with the blessing of the Almighty, we start today's webinar for the smooth conduction of this webinar. And so I would like to welcome our coordinators of the program, Dr. Ankur Shah and also Dr. Balaji. So Dr. Ankur Shah, Dr. Ankur Shah is an alumnus of Mukshi Medical College and also Armed Forces Medical College, Pune. And he is trained by none other than our renowned Dr. Sanjay Patel. So it is good for our the own student to introduce the teacher. And also he is currently posted in the Command Hospital, Pune, and also has more than 18 plus years of experience. He's also a postgraduate teacher, and of course, he's one of our young member of the Youth Council of IAG, and also has varied interest apart from his academic activities. So the second coordinator for this program is Dr. Nalwad Balaji Reddy, who is also a very eminent endoscopic surgeon from Pune, who is also a robotic and endometriosis surgeon, and also the director of the Libya Advanced Fertility and Endoscopic Clinic. So I would like to welcome both our young coordinators to introduce our chairpersons and take forward the proceedings.
Thank you so much, ma'am. This series would not have been possible without your support. So, before we start off, a small brief about Dr. Malaraj as well. Ma'am is quite well known and is the founder secretary of the Tamil Nadu chapter of IAG and having a host of awards to her credit. She's currently as the managing director of Firm Hospitals, and thank you, ma'am, for the kind words today. With this, we take over with to the first session of demystifying endometriosis, to be taken by none other than Dr. Sanjay Patel. And to chair this session, I would like to invite Dr. Rekha Kurian, who is a director and consultant of Joseph Hospitals, Chennai, and also as a honorary consultant in Southern Railway Hospital at Chennai. She's been the chairperson of IAG Tamil Nadu chapter and the vice president of Foxy at 2015. Ma'am, I would like to welcome on board this series, and I would like to introduce Dr. Sanjay Patel, sir.
Yeah. Good evening, everybody. And this is a lovely session which has been organized by IAGE. And I'm very glad to be chairing the session with Dr. Sanjay Patel, whom we have been friends for a couple of decades now. While we are operating faculty, we'll have good chats. Yes. So it is really nice to have an opportunity to chair this session. Because I've seen him operating from decades ago, excellent surgery, and with his friend Dr. Praveen Patel, all of them used to be excellent surgeons. So they carry that legacy forward. And I think you'll be the right and the apt person to talk to us about deep infiltrating endometriosis. So over to you, and you can tell us how to solve this enigma of endometriosis. So how to manage it. Peritoneal endometriosis, I think, is a topic that you are going to do, and why peritonectomy is becoming more and more a new type of surgery in our field now. Over to you, Dr. Sanjay Patel. Everybody is waiting to hear you.
Thank you, Rekha ma'am, for the kind words. And also special thanks to the Dr. Malaraj, my dear friend Sujal, Kalyan, and Sejal, and entire team of the IAG. Today, my subject is related to, actually, we invented the one of the technique is the Mayflower butterfly technique. I tell you the short prequel story, why I invented it. In 2008, I encountered so many patients presented with the burst endometrioma. And I find out that CA125 level is rise more than 1,000. And the one patient is 16,000 CA125. This one is due to the peritoneal reactions. And then we realized that I think this is the peritoneal disease rather than other thing. What we done in the CA over is the same concept. I think in this disease is we needed. And that's why the CA125 is rise, particularly in cases of the endometriosis. We not discuss related to this part, but I think the most important is implant over this peritoneum over a period of time. It's invades inside, and over a period of time, it's developed the white lesion. And look, the burst endometrioma. And at the same time, patient is presented with the severe pain and CA125 rise more than 1,000. So this is another case. And then we kept in mind, when it's the multiple implant over this peritoneum, I think the best approach to remove the peritoneum, and that's why en bloc removal of the particular this pelvic peritoneum. Look here, in this case, it's the multiple small implant over the entire peritoneum. And this is the technique I think we developed it. First, we dissected parallel to the ureter. This is the torus uterus associated with the rectovaginal plate involvement. Now we enter in the middle parietal space, the most important part to preserve the hypogastric nerve. Nerve sparing surgery is really definitely role, particularly in the advanced cases of the endometriosis. Then we try to make the split it. Later on, I explain it, why we split the peritoneum between the rectal plate and between the rectum. And this is the upper wing of the butterfly. Thus, we try to make the exercise, we try to make the do and the en bloc. The principle behind to this Mayflower butterfly technique, en bloc removal of the entire affected peritoneum. So it's reduced the recurrence rate, and it's also improve the fertility outcome. Not only the fertility outcome, but it's improved the related to pain score and related to dysmenorrhea and menorrhagia. Because the rectovaginal plate is one of the important part to involve it, and it's interfere related to sexual life of the patient, and this is the main cause related to infertility. We believe it. And look here, this is the looks like the butterfly, and that's why we call the Mayflower butterfly. We started this approach in the 2008, and we are extremely happy with this approach. Another one case where it's developed with the multiple, it's the invasive nature of the particular this disease, and it's involved the entire peritoneum. Look here, this is the very advanced case associated with the bilateral chakra. We try to use the 1000 probe. This is the one of the best tool we prefer, particularly for the endometriosis surgery. And look here, this is not only, this is the frozen pelvis, but entire the pelvic peritoneum. It's, I think, affected with this, particularly with this disease. So first we try to identify the ureter. This is at the level of the pelvic ring. We try to make the dissect anterior to the ureter and try to make the preserve the vascularity of the ureter. Still today, none of the drugs available in the market to prevent the further growth of the endometriosis. So I think surgery is considered to be gold standard. And look here, this is the entire affected peritoneum just below to the ovary. This is in the ovarian fossa. So not only try to make remove the some part of the peritoneum, but if possible, better try to make the excise all the inflamed and affected peritoneum. So another side, I think also we try to make the dissect at the level of pelvic brim. First, we identify the ureter. Above the level of ureter is the upper wing of the butterfly, and below the level of the ureter, this is the lower wing of the butterfly. And we try to create the mathematics particular for the endometriosis surgery. Any kind of the cases, even though it's a frozen pelvis, we try to make the same principle. First, we try to identify the ureter, dissect parallel to the ureter. Then we try to make the dissect above the level of the ureter, and we try to remove the entire affected peritoneum. And now we, I think, focus related to this torus uterinus. This is the rectovaginal plate in the behind to the cervix. And here also very important to, I think, dissect the middle parietal space, because uterosacral is also involved and associated with the parametrium involved in this disease. So we try to make the dissect parallel to the colon. We excise the anterior peritoneum above the level of colon. And this is the below to the ureter. This is the posterior wing of the Mayflower butterfly technique. Go step by step. I think with the tip of the particular harmonic scalpel, I think if you use over this peritoneum, it's dissect well, because the cavitational effect of the particular this instrument, it's, I think, give the lot of help for the proper dissection of the peritoneum. And now it's looked at. This is the ureteric involvement associated with the uterosacral involvement with the parametrium involvement. Put the small niche try to make the stretch. Majority time in the DIE, deep infiltrating endometriosis with a lot of inflammation, this loss of the elasticity of the tissue. And now you look, this is a very important part. You split the nodules. This is very important. Then again, we dissect the above the level of ureter, entire end block removal of this peritoneum. And look here, I think if you go step by step with dissect with this tip of this harmonic carbon, majority time you get the good plane of the vein. The vein is really nuisance at this stage, and you take care for this vein. Sometimes the vein is involved with this disease. You also sacrifice the vein. In this case, look here, this is the uterine artery and this is the vein here. And now I think, focus related to this is the right side of the parametrium associated with the entire torus uterinus with the rectovaginal plate involvement. Now also this is the below to the ureter. We dissected, we enter in the middle parietal space. And all the affected peritoneum over this colon and lateral wall of the particular colon, we try to make the remove it. This is also a small ureteric nodule, and that's why the kinking of the ureter is happened, and that's why little dilated ureter. Always fat is belongs to the bladder, fat is belongs to the rectum. So try to make the dissect the fat, and also you very carefully you take care for this vagina, because sometimes in such cases also involved with this vaginal involvement is also happen in such cases. And try to make the save the affected vagina. It's also very important. So entire specimen we remove in the end block. And look, the entire pelvic peritoneum we remove it. And look the picture of this one. And this is the middle part is the body of the butterfly, and four wings is the like the butterfly, and that's why we call the butterfly technique. This is very advanced case with the multiple nodules over it. Even though diaphragm is also involved on the particular left side and also the right side, just below to the heart. This is the entire peritoneum is involved in this disease. This is all our lacunic collections. We have to have the remove. Whatever the advanced case, the same principle we started with this Mayflower butterfly technique. And then we deal with the vaginal nodule, rectal nodule, or other implants. Here, this is the right iliac fossa. This is the endometriosis implant. You don't want to leave it. And again, I tell you, the gold standard is the excision of the endometriotic nodules. This is another one nodules. So above the level of the pelvic brief, sometimes whenever the visualized nodule, you try to make the exercise, but it's the more affected chunk is involved. In this case, is also you try to make the remove and block, like what we done in the CA ovary. This is the middle parietal dissections. Now we do the splitting of the nodules. This is associated with the rectum nodules. And then entire affected rectovaginal plate, we also excise it properly. This is the small nodule, is the pouch of Douglas. We also excise it. This is the posterior wing of the butterfly associated with the parametrium involvement. So we excise the posterior and transverse parametrium. This is another multiple nodules over this bladder, but it's not involved the mucosa of the bladder. In those cases, you should try to do the saving. But over a period of time, because every monthly is going, inflammatory process is going on, and that's why if you leave such kind of the nodules, maybe over time, it's maybe presented with the mucosal involvement of the bladder. Always I prefer to fill up the bladder. It's always good. And even though over this round ligament, this is all the nodules, we remove it. Peritonization happen within the 24 hours. Even though we do the relook surgery, and even though during the time of cesarean section in conservative approach, fertility enhancing surgery, we visualize that. I think sometimes you find out the pelvic is absolutely looks the virgin. But do the proper hemostasis. It's very important. And try to make the exercise the thorough endometriotic nodules. Now, this is the also entire thickness of the diaphragm is involved in this case. This is above the level of kidney. Just we lift up the liver and we excise this affected peritoneum over this kidney. Also on the lateral side, because this is the area of the lower hanging ribs. And sometimes patient may be referred pain in such cases. See, this patient have the typical history during the time of menstruation, have the shoulder pain and pain over these lower ribs. In MRI, this is the entire diaphragm is involved, whole thickness. So we excise the diaphragm. Particularly during this time, the anesthetist plays a very big role. Once we open, the gas is entered inside the thorax. So ICD is also kept ready in such cases. We open the diaphragm. And look here, whole entire thickness, I show you in little while. This is the entire thickness of the diaphragm is involved. We warn the anesthetist, and immediately anesthetist increase the respiratory rate and decrease the tidal volumes. And also we kept the ICT. Look here, this is the whole thickness of diaphragm is involved. Then we look inside the thorax. The rest of the thorax is normal. This is azygous vein, the collapsed lungs, and no endometriotic implant we find out inside the thorax. Most important part in such cases, because this is the odd place, suturing is also very difficult. So we prefer to always take the VLOC 20 or 30. 20 is better one. I think this area is protected by the liver, and there is a less chances of the hiatus hernia or less chances of the hernia, because immediately post-operative there is a ample of chances of the adhesions with the liver. But the right side, near to the heart, it's also night bear. We face the one complications. We try to make the exercise this over this heart, this affected diaphragm. And the very important part, before you close it, we put the suction inside, try to make the suck out the entire air, increase the tidal volume, and then gradually you tight the thread and remove the suctions. So I think sometimes if you manage properly, there is a less chances we keep the ICT. Sometimes we prefer to take the double layer. But right side in the MRI, there is a not entire diaphragm is involved. So we do the fulgurations. We done the one mistake. I think small knee can we suture it. Due to this movement, I think on the right side patient is developed the hernia. So always on the right side, due to this is heart movement, always there is a higher chances of the, even you suture it, this diaphragm, there is a ample of chances of the tear of this teeth line and develop the hernia. So always on the left side, whenever the affected diaphragm, we try to make the exercise. Now we discuss related to rectovaginal plate and parametrium involved. This is the also gateway, nothing but the gateway of the peritoneal involvement. And look here, this is the patient is presented with the severe dysmenorrhea, menorrhagia. So I think this is the entire rectovaginal plate is involved. We excise it. And try to make the remove this one. It's improve your fertility part. In our center, I think 30% patient is carrying the natural pregnancy after the endometriosis, fertility enhancing endometriosis surgery. Those who underwent go for the multiple time IVF failure. In these cases, look here, the same principle, we do the peritoneectomy in these cases. Then the very important in this case is we split the rectal nodules because it's the 8 centimeter long rectal nodules and 6 centimeter, I think, vaginal involvement in this case. So first we excise the peritoneum, pelvic peritoneum, thoroughly. Look here. And then we now deal with this vaginal nodules. So this is the gateway for the vaginal nodules. So peritoneal implantations, if you live in the pouch of Douglas or in the rectovaginal plate, there is higher risk of develop the vaginal nodule and even the colorectal nodules. So this is the 6 centimeter of the vaginal nodules we excise it. Also big 8 centimeter rectal nodules. So we splitting of this nodule first. We mobilize the vagina properly. Because anytime if you deal with the colorectal nodule, you have to have mobilized colon properly. So now this is the case, I think it's the peritoneal involvement with the vaginal involvement with the colorectal involvement. So only the peritoneal involvement is not happen in all the cases. Majority is associated with the parametrium involvement, vaginal involvement, and rectum involvement. In this case, I think this is the muscularis involvement. So we do the saving over it. And we will also sacrifice some of the muscularis portion of the colon. So first we save over it. We remove all the entire nodule. And if we sacrifice little bit muscularis portion of the colon, we prefer to take some stage stitches whenever we find out the thin muscularis. For the safety purpose, I think if you take the couple of stitches, it's always better in such kind of the cases. Look here, this is the long nodules over this rectum. Also, we find out the lateral vaginal nodule in this case. This one is the gateway from the parametrium to the lateral vaginal nodules. So also we excise it properly. And then we suture the vagina with the 2-0 V-lock. And colonic suturing we done with the 3-0 V-lock. Just we do the good approximation of the thin muscularis portion. So I think, believe me, this is the peritoneal disease, and due to this corrosive and invasive nature of this endometriosis, I think the small implantation over a period of time converted the DIE, deep infiltrating endometriosis. So you have to have the exercise, the thorough peritoneal involvement of the endometriosis. Thank you. Thank you very much.
Thank you very much, Dr. Sanjay Patel. That was a wonderful elaboration and fantastic videos. I think it's really exceptional, your dissections. I have also had chance to do some of these very deep dissections, and I totally agree. You have to split the nodule so that part of it is still on the rectum, and then the most of it is taken off with the uterus. Then very gently lift up these endometriotic nodules and find the plane and cut in between without hopefully entering into the rectum. And as you said, it is better to just put couple of sutures. My question is, when you put couple of sutures across, I've done that also, whether it will cause any narrowing of the rectum. Have you had any
I think that's why I show, if you look this video lastly, you
Yeah.
find out I pushed the rectal probe. And the rectal probe is passed through very easily. That
Then
means
that
there
is
is
okay.
very less chances of the narrowing, because the lumen of the colon is very big.
Yeah, yeah,
If you do the little bit anterior surface, if you suture it,
yeah.
I think the over a period of time, colon is expired on the posterior surface of the
Okay.
colon.
Okay.
So I think narrowing of the particular, when the nodules is very big, and if you go for the discoid,
No.
always we try to
Of
make the
course.
suture transversely.
Transverse.
But I think it's the more than 40 mm size of the nodules and more than 7. In those cases, I think there is some chances of the narrowing. And that's why the cutoff limit.
Yeah.
Even the 30 mm, more than 7 mm invasion, in those cases, I think go for the bowel resection. But in
Okay.
our center, we tried up to the 40 mm, and we are extremely happy because this is the benign disease only involved on the anterior compartment of the colon. So I think whenever you try to get the chance, better you go for the organ sparing surgery.
Yeah,
This is a
exactly.
very important part.
I totally agree, because we otherwise it becomes too distressing for the patient, and especially if it's an infertile
Treatment
patient.
should not be worsened than the disease. LAR
Yes.
syndrome is really very worst.
Yeah. I want to also ask you, in such a case, if the patient is infertile, when will you then ask her to resume infertility treatment? Would it be the very next month?
After 2 months, because there is some inflammatory process is going on.
Okay.
So you
So
have to have to settle down all the inflammatory process from the pelvis. Because any inflammation, it may be interpreted related to so many chemical and biochemical substance like interleukin, prostaglandin, and so many things. So I think at least you give the rest for the 8 weeks.
If the patient is not interested in infertility, would you put her on anything like Dynogest or GnRH, anything like that, analogs?
All are very worst tablets.
No, but after you have taken out every
Because what's
endometriosis.
happened with we have the couple of cases, majority our center is the tertiary care center for the endometriosis. The patient took the 6 dose or 8 dose or 12 dose of the leupride. Patient is took 2-3 years for the Dynogest, Ugolagix, so many drugs, Letros, please, Registron. I think this all the drugs is create the loss of the elasticity of the tissue.
Yeah.
It's just like the rubbery tissue, and then it's created the major issue for the surgeon.
Okay.
And it's increased the complications rate during the time of surgery. And that's why any drug you given to temporarily to postpone the surgery for the couple of months, but not more than 4 months. It's absolutely my clear statement. This is all are placebo, and company people is earn the billions of rupees after the such kind of the drugs.
Okay. My question is, after you have cleared all the endometriotic peritonectomy, then will you give it to prevent recurrence of the disease?
One important part, if you clear, again I tell you, the gold standard is the surgery, surgery, and surgery.
Yeah.
If you thoroughly remove the entire whatever the visualized disease,
Yeah.
I think it's give the wonderful outcome. It's even though in the fertility enhancing surgery, there is ample of chances of the recurrence, but due to the good surgery, it's the delay of the recurrence, it's improve the fertility part, and it's improve the quality of the life of the patients.
Okay.
So
I agree. I've looked for other questions in the box. There are no more questions. Mala, would you like to ask something or anybody else?
Yeah, I would like to have one clarification, sir. So while you're doing this excision of the diaphragm, as you are excising, you're putting a drain into the thorax, is it, for to prevent pneumothorax? How is it happening?
I think that's why I put the suction scheduler.
Okay.
Before you tie the last knot and you squeeze the, I think, V-lock, you try to do the suctions thoroughly. Because we do the couple of cases, and it's a good number of the diaphragmatic involvement of the endometriosis, we remove it. And I think we realize that if you put the suction and suck very regularly, your anesthetic is good. At that time, you plump the lungs and try to make the suck out all the CO2, whatever in the thorax. I think less chances to keep the ICD in these cases.
In this diaphragmatic endometriosis, have you ever diagnosed it before going in?
Yes. Yes. If the good MRI center always is pick up this one.
I see.
So
Okay.
you will have a cardiothoracic surgeon also along with you, sir, or you are only going to do that?
We have this is entirely for this disease, we require the good teamwork.
No. Okay.
Me, my son, because whatever you look, the last all 3 videos is done by the Smith. I think we have the another one GI team with us. It's a Dr. Laxman Keria. So good teamwork is required for the particularly such kind. But I think no need of the cardiothoracic surgeon in such kind of the cases.
Okay. So any kind of post-operative morbidity, sir, after this diaphragmatic excision, what are the things that you need
I
to
think related to morbidity part, whenever the hydrothorax is happen, you put the ICD in these cases, one of the part. And sometimes I think there is a higher chances of the particular hernia. But in this case, the left lobe of the liver is guard the such kind of because once you remove the gas, automatically it fall down. And majority time the liver is adherent with what we do in some of the cases of the reduced laparoscopy, we visualize that liver is adherent. But on the right side, it's the dangerous part. We done the one cases, it's a very small, only the 2 centimeter gap. We try to make, because this diaphragm is little bit thinner than the left side of the diaphragm. Okay, and due to the movement of the heart, sometimes whatever you take the suturing, I think tearing of the suture is happen, and this patient is presented with the hernia. So I think mortality aspect, I think don't worry related to this part, but only the part related to hernia.
The right or the left diaphragm is thinner, sir?
Pardon?
Left is thinner.
Yeah. So the left diaphragm is thin, no, sir?
Yeah.
Yes, sorry.
Yeah.
I visualized by the laparoscopy, and that's why I told that this is the left.
Yeah.
Because I am the laparoscopic surgeon.
We
Always
understand.
kept in my mind.
We understand,
How
sir.
long do you keep this drain, sir, after surgery?
Pardon?
How long you keep the tube for prevention of pneumothorax?
I think as such in our series, I think we done 12 or 13 cases. Not a single cases we need to put the ICD. But I think there is no bravery in the medical field. So I think whenever if any doubt, I think put the ICD.
Yeah.
Okay.
Ankur is with us. I think he see so many cases of the diaphragmatic involvement. He is doing the excellent. He is the great surgeon and doing the excellent work in the Army Medical College.
Thank you, sir.
Fantastic.
There is one last question before we go on to the next session, sir. That was asked is the port positioning during excision of the hepatorenal and diaphragmatic endometriosis any different from what you normally do, or do you take an additional port, sir?
Yes, I think absolutely. This is above the level of umbilicus. So you put the extra 2 probe, just like what you do for the gallbladder, same position you do it. And also you change the entire camera. Okay? Because from the leg side to the particular for the head side, I think you put the angle on the like this one safely. Definitely, I think I tell you that even though the expert endo suturing person create the problem in particular for the suturing of this one. Because it's an odd angle and space is also different one. So I think sometimes it's create the problem for the suturing. But I think good endoscopic surgeon definitely do this job very easily. And I think B-lock is considered to be one of the magic thread for this one. If you use any Bicryl or something, then it creates a lot of problem because tightening is one of the issue. And just you take the one by one suturing is very difficult. If you take continuous with the B-lock and then you tighten, there is a ample of chances of the get the space. But I think V-lock, once you tied it, I think this is the best suture material for the diaphragmatic suturing.
Dr. Jay has a point, sir.
Yes,
Jay, if you
Jay.
can unmute yourself, sir.
Hi, audible?
Yes, Jay.
Yes, yes.
Sir? All good.
All
Yeah.
is well. All is
Yeah.
well.
Just wanted to mention something about the positioning which sir was mentioning as far as diaphragmatic endometriosis is concerned. One good thing which we can try to do in hepatorenal and diaphragmatic endometriosis is what we actually give a position when we are doing unilateral nephrectomies in endometriosis. You can keep the patient in a lateral position. So what will happen is majority of the bowel falls off, okay, onto the other side of the abdomen, and give approximately 12 to 15 degree head up to the patient. In that situation, you will believe and you will start noticing that when you cut the coronal ligament of the liver, and the liver is going to fall down towards the midline of the abdomen, understanding you will not have to apply any traction to the liver. So there is no tear onto the Glissen's capsule. That is an important thing. And second, as sir mentioned, that angle is very difficult to suture if in case we have to suture there. But if you keep the patient in a lateral position, your suturing becomes super easy as far as that is concerned, because our hand movements being righty or lefty surgeons become very, very easy. So if people want to try, they can probably try that.
I think due to the liver, sometimes we not encounter if you do the little bit head up positions, I think intestine is very far away. Only the one question mark because our team is not ready to cut this ligament. Because ligament, if you cut it, there is another one issue. I think we not discuss in this one. So I think whenever it's possible, we try to make the avoid to cut this ligament because it's the ligament is the safeguard this one. Only you get the advantage the liver is going down. But I think if you have the good team, I think small tear of the liver is happen nothing because in this cases, this is the healthy patient. Even though INR, this is not the like the cirrhosis of liver or something. So I think liver tear chances is comparatively very less in the cases of the endometriosis. Second important part. Even the small tear is happen, sometimes you put the surgical and trace it. I think majority time is controlled well. Because we encounter the same things what you're telling, I think, in our series. There's some needle, even the pass from this one of some laceration of the needle is happen, I think. But you put the surgical over a period of time, is controlled well. And sometimes if you feel any using, just you put the drain for the 24 hours or 48 hours. But I think if you judiciously take the stitch, I think there is a less chances of the injury of the liver.
So you don't give any post-operative medical management at all, sir, even in these extensive cases to prevent recurrence, because the nature of the disease is such as even how much over you exercise, there is a chance for recurrence. So how do you prevent recurrence in such cases, sir?
I think this is agar Mala, if we have this answer properly, I get the Nobel Prize for the thing.
True, very true, sir. We seriously don't have an answer for that. I was thinking whether you are doing something, for your patients.
I spent my 30 years behind this disease, adenomas and endometriosis. Still is the big enigma for me.
Very true.
Well, Jay is also agree with me.
Sir, we have a rule here that if there is multi-compartment endometriosis and if the patient is post-operative, after having radical excision, we will give them one shot of Zolodexer. So it is not that we don't give any post-operative management. And if the patient is a young patient, let's say an adolescent patient, or marriage is 5 years away, then at least what we do is that after the patient gets the primary withdrawal, after Zoladex. So let's say around 4 months, so around 120, 130 days later, of 10.8 grams of Zoladex, they will get a primary withdrawal. After that, these girls, they will follow up with us, but we will make sure that they will have only 2 menses in a year. So we then put them on prolonged OCP combination, sir. We give them around 150 days of OCPs continuous, take 25 days break. Again, you are on 150 days of OCPs continuously, take 25 days break till they are getting married. So we are definitely giving post-operative suppression to the patient if marriage or children or whatever or any form of fertility is far away. We are not because recently we have started to see, and I think everybody who is operating endometriosis would have started to notice in the last maybe 2 years, 3 years, 5 years, whatever. I think post-COVID, we have all started to see very unnatural extrapelvic endometriosis for people who have been operated in the pelvis long back and not been suppressed. Like we have ended up seeing things very randomly, splenic endometriosis, hepatic endometriosis, and I think all of us would have seen this in the recent past, especially in the last 1 to 2 years.
I think, Jay, actually, in 2003, we started to give the Lupride depot. What we believe that what we clearance we done is the macroscopically.
Yeah.
Microscopically, we couldn't know. And 2003 to 2014, we give the 11.25 Lupride depot or Zoladex, whatever be.
Yeah.
And then we do the one trial, I think from 2014 to the 2019, and we realized that it's make doesn't difference. I think related to it outcome. Second important part, we prefer to still give the OC pills, but not with the continuous. Because if you give with the continuous longer time OC pills without break, the side effect is much more. The water retention and so many things, I think. Even though sometimes patient is presented with the breast pain. So I think the best approach we realize that if needed, give the till our center, we give the OC pills for the longer time, but it's a breakthrough. 21 days, we give the gap, then again we give the OC pills. So I think this is the same scenario we done it. In my era of the last 3 decades, I do the everything. Okay. But I think still the right answers related to this part, it's big question part also for the big.
How about elagolix, the GnRH antagonist?
Elagolix is also worse than the Dynogest. Never use it. Jay, what's your opinions?
No, the good thing about elagolix is the company people have itself limited the use to 6 months. Okay, so 200 mg twice in a day, maximum 6 months.
6 months, isn't it? The elagolix, they don't have more data, and they have.
But they have data that in 6 months, around 7 to 8% of patients taking elagolix pre-surgery or post-surgery will end up with irreversible osteoporosis, and that is a very worrisome data. So I personally think, as Sanjay sir said, maybe post-operative suppression if you want to give OCPs or Zoladex, but pre-operative randomly prescribing elagolix just for pain management, I think a much better option is to switch them to an endoscopic surgeon as and when required and try to get it cleared.
Yeah.
I add the one point.
That's a point, yeah.
Actually, even though what we thought that if you give the only Lupride depot, and patient is maybe have the osteopenia, bone pain, body ache, weakness and everything. But I think in our center, we realized that patient took the anabolics and patient took the Dynogest for the longer time associated with the bone pain. And if you go for the bone scan, I think there is the osteoporosis we find out. And I think this one is all drugs, maybe indirectly correlated with the Lupride is proved that I think it's create the osteoporosis. But other drugs, I think what we observe in our center also affected related to bone density.
Yes. So I think lots of discussion has happened, and almost we've taken 1 hour, I think, on this particular topic earlier.
So I think we can go on to the next topic.
Yeah.
So thank you very much for this opportunity to IAGE, Dr. Mala. And I think the next chairperson will take over.
Thank you so much, Rekha madam.
Thank you, Mala. Thank you.
Thank you, sir.
Thank you, Dr.
Kalyan,
Sanjay.
Sejal, and Ankur. Jay.
Yeah.
Also, I am continuing in between. I continue with this meeting.
Yeah. Please stay back, sir. We can also hear the other speakers. We have all eminent speakers today, so you can also contribute in between. So we like to welcome the next chairperson, Dr. Ankur. Can you please introduce the next chairperson?
Yes, ma'am. The next person is also no stranger to us. I'm more than happy to introduce Dr. Sujal Munshi as our next chairperson for the next session, that is on bowel endometriosis. Dr. Sujal Munshi, other than not only being my college senior, has been a long-time friend and somebody I have always looked up to. Consultant OBGY at Kalpana Munshi Hospitals, the secretary of IAG, and I think that probably should sum up whatever Dr. Sujal stands for. A long list of awards and positions that he's held. I'd like to invite Dr. Sujal to please go ahead with the next session.
So for the next session, we have very dynamic, young and very experienced surgeon, Dr. Jay Mehta. Am I clearly audible?
Yeah, very well, very well.
So I must say here that past 1 decade, a lot of things have changed. Sanjay Patel sir, Jai, Devin, everyone has broadened the horizons of gynecology, and we see gynecology now in a very different way because all of you. And one of the most controversial area, which was never falling in the category of gynecologist way back, has now been a very integrated part of it. And we would like to hear from you, Dr. Jay Mehta, your experience on this bowel endometriosis. Please go ahead.
Yeah. A big thank you to all of you from IAG for having me over at this event. And I have been asked to speak predominantly as far as managing complications for bowel endometriosis is concerned. So I will start off. I will, as most of the times I have stopped showing videos at all these places because multiple videos are now available across social media platforms. If possible, I'll try to draw and tell some things which we need to remember when we are operating on a bowel complication, basically. And we also need to remember certain things which we need to follow in order to avoid a bowel complication. So these are the two broad things which I'll be speaking about. But just in case somebody is in a hurry, as has always been, I'll start the lecture with take-home points. Okay. So the 3 or 4 important take-home points about managing bowel complications is concerned. The first thing you should remember is that a bowel which has been repaired, okay, has to be a relaxed bowel. And that means the mobilization of the bowel is extremely important in order to achieve sufficient relaxation and extremely good healing for the bowel. And that is something which is very, very important in any bowel surgery, be it endometriosis, be it colonic surgeries, be it hemicolectomy, segmental bowel resection, discoid excision, whatever bowel surgery you do, the site of anastomosis has to be relaxed and it has to be tension-free anastomosis. That is an important point which will help you drastically reduce the amount of leaks and the amount of bowel injuries which you may encounter during your practice. That is the first point. The second important take-home point is if the patient is having a persistent non-settling tachycardia, pulse of the patient, post-surgical. If the patient is complaining, if the patient's monitoring criteria is demonstrating a tachycardia which is not settling down, usually within 18 to 24 hours of the surgery, usually things will settle down. But if there is a persistent tachycardia, then keep one thing in mind, that there could have been something in the bowel which you should suspect. Do not miss out on that. Do not wait for your drain fluid to start showing fecal matter. Do not do any of these types of things. All right. A persistent tachycardia is something which is going to be your first warning sign as far as this particular bowel injury or a suspicion of a bowel injury is concerned. Right. Now, coming to the third thing. Though a lot of people will say that there is some controversy as far as giving bowel preparation versus not giving bowel preparation is concerned, if you are a practicing gynecologist who is predominantly operating onto the lower bowel, that means if you are predominantly operating on the sigmoid and the rectum, these two are the places where we predominantly operate upon. If you are operating here, okay, then it is very wise to have that part of the bowel as an empty bowel. The reason why is because there is an abnormal amount of gaseous distension which can be handled by both the sigmoid as well as the rectum. Because sigmoid is the place where you have stool storage, and rectum is the place which is a high pressure zone as far as manometry is concerned, where there can be a lot of passage of stools in a lot of force following the gastrocolic reflex. So if in case you plan to repair these two parts of the bowel, we encourage you to maintain bowel preparation and to have a clean bowel. That is important. You may choose to not give bowel preparation when you are doing ileocecal anastomosis, when you are doing ileal anastomosis, you are operating on the small abdomen, I mean small bowel. In all these places, bowel preparation may or may not have a role. But in our situations, in a gynecological situations, do not fall for that practice that you want an empty bowel. I also want to point out a lot of things as far as that important study was concerned, is that majority of the surgical procedures which were carried out as a part of that colonic study were for laparotomy. So what typically happens in laparotomy is you can squeeze the bowel out from both the sides, empty out the stools from there, stools go on a gauze piece, and the bowel which you are anastomosing is still an empty bowel. Understanding? And that is usually not possible when you are doing laparoscopic surgery, and that's why you should have a well prepared bowel in laparoscopic surgery, right? That was point number 3. Coming to point number 4. Lot of times in our counseling as surgeons, we hear from people that, I am scared of doing endometriosis surgery because somebody has told me that you will require to do a colostomy, or somebody has told me that, you will require to do an ileostomy. Fine. So there is a massive difference why we would recommend an ileostomy as compared to a colorectal surgeon recommending an ileostomy. If you see, the predominant segmental resection and anastomosis which is done by our colorectal colleagues is for patients who are having a malignancy. And if you study, like we have a onco unit here in our hospital, so I'm very close to them because I do some endoscopic work with them, and they call me for some of their resections. So if you ever touch a malignant bowel, you will realize one thing. Lot of these patients would have received a short course of pre-surgical radiation to reduce locoregional disease. A lot of them would have received 2 or 3 or 4 cycles of chemotherapy, and then they are posted for surgery. What typically happens in that situation is, because of the local pelvic radiation, there is already a good amount of microvascular damage which has occurred to the local area of the rectum. And our colorectal colleagues would recommend a temporary diversion ileostomy because the bowel which they have anastomosed is not a greatly vascular bowel. This is the exact reverse of what happens in endometriosis. Everybody would agree to me that in endometriosis, you have good amount of neovascularization at the region where the lesion is. So when you do segmental resection and anastomosis, these patients do not require a mandatory ileostomy. Yes, there are definite indications for doing ileostomy, especially when the lesion size is more than 6 centimeters and it is less than 5 centimeters from the anal verge. That means it is very close to the levator ani muscle where there is high tension. In that situation, in order to avoid a fistula, you can have a temporary ileostomy. So on an average, we will do around 7 to 10 ileostomies in a year. And that is predominantly because we have such a high volume of operating low anal disease all across the country. So I am talking of 7 to 10 ileostomies across India. And that is a very small number if you compare to the total number of surgical procedures which we will be doing for this disease in the country. So that is an important take-home point. And the final important take-home point, all right? Whenever there is a leak in the bowel, there are 3 important things which you have to do. One is diversion. No questions asked, do diversion. Do not fidget with that region, just do diversion. Second, most of the times, the patient, by the time we recognize and we intervene, the patient will require an ICU backup. So kindly operate these patients in an ICU backup, because fecal peritonitis otherwise carries a mortality of in excess of 30% even for young patients. If the patient is an old patient, let's say 50, 60, whatever, though fortunately we don't get so much endometriosis in that age group, but if you see an old patient with fecal peritonitis, the mortality rate is more than 50%. And if you add any comorbidities to this, for example, if the patient is a pre-existent diabetic, pre-existent, let's say hypertensive or whatever, pre-existent autoimmune condition, whatever, in that situation, the mortality would cross 65%, right? So one has to be careful that if you recognize this, kindly take the patient to a place where you have a backup of an ICU available, because this patient, majority of the times, you will realize that as soon as your diversion is done, and if the patient has been compromised, your anesthetist is not going to allow the patient to come out of the ventilator. And most of the times, the patient is going to be shifted in the ICU on a venti. And the patient will be on a venti and on NORAD support, that means cardiac support, for the next 48 hours. Usually the patient turns back in that situation, and that is when you are going to be relieved. So that is an important point number 2. And point number 3, and I think this is an important take-home point for everybody. Please, when you start operating on endometriosis, please start taking procedure-specific consent for every endometriotic pathology which you are operating. For example, if you are operating on cecal endometriosis, take procedure-specific consent for cecal endometriosis. If you are operating discoid excision, take procedure-specific consent for discoid excision. If you are doing segmental resection, take a procedure-specific consent for bowel resection. And I think that is going to give you a good night's sleep as far as continuously handling bowel endometriosis is concerned. Out of my experience for handling a good number of complications as far as bowel endometriosis goes, see, I am one of those lucky guys who has operated in every state, and that is why I have had a patient whom I have complicated in every state of India. Understanding? So I would have had a complicated patient in Gujarat, I would have somebody complicated in Bangalore, Chennai, Tamil Nadu. Everywhere where I go, because of the volume, you will have somebody or the other who has ended up in a complication. So there is no question in that. One thing I realized, the thing which really saves you at the end of the day is a good indemnity insurance as well. When you are operating so many these types of patients, if you are at this level operating these patients, kindly upgrade your indemnity insurances to more than 20 crores and do not stay at that 5 crores and 2 crores mark, because that may or may not be sufficient to take care of your things, right? Some more points which may or may not be take-home points, but I think they are important points as far as management of bowel endometriosis is concerned. Okay, in order to avoid the complications, I love to do a good preoperative ultrasound. If the bowel disease is more than 3 centimeters in size, okay, majority of the times the patient would require a segmental bowel resection, and it is good to counsel these patients for a segmental bowel resection before the actual surgical procedure would start, right? Majority of the times, a disease in the bowel which is less than 1.5 centimeters in size, and on axial ultrasound, if it is occupying less than 15% of the circumference, 1.5, these are the lesions which do not require segmental resection. They will heal beautifully well with a discoid excision. Okay. One last point before which I think, since I have also finished 15 minutes, I also want some time for discussion and not to prolong the program. If there is a primary injury of the bowel in your endometriosis surgery, we have shifted exclusively to suturing it back using Stratafix. We do not use silk. We do not use PDS. We use Stratafix. Number one, you can use either Stratafix. We use a combination of Stratafix and Quill both. Okay, and both are extremely good as far as bowel healing is concerned. Single layer suturing over the bowel, okay, in the same plane in which the incision is, and that really helps. And now is my final point. If you have done a segmental resection or injured the bowel, the first thing you should do is start the patient on early fluids within approximately 8 to 12 hours of the procedure. So I know this is debatable, and people are going to tell you that this is not done. You need to keep the patient NBM because your anastomosis is new. But remember one thing, because the anastomosis is new, you do not want paralytic ileus to set in. If there is a paralytic ileus setting in, the gaseous distension of the paralytic ileus itself causes a huge amount of tension on that anastomosis, thereby weakening that anastomosis. And as a result of this, on the second post-operative day, that means 24 hours after surgery, make it a rule to monitor the electrolytes make it a rule to monitor the albumin. Remember, albumin has to be corrected, potassium has to be corrected, and these are two potentially correctable points for reducing complications of your bowel procedures. Right? Finally, one medico-legal thing which people will ask, so I'll just answer that do we keep a colorectal surgeon or a gastrosurgeon or a oncosurgeon with us in the team when we are operating bowel endometriosis? So I think the answer to that question is very straightforward. God has been kind to us that we have not lost a court case. We have not even, we have filed PILs for this, and nothing has gone against a gynecologist doing a procedure which is mentioned in his or her textbook, which is a standardized textbook. So fortunately, if you look at gynecological surgical textbooks, they have started mentioning bowel endometriosis as a separate chapter. And if bowel endometriosis is mentioned as a separate chapter, as long as you are trained in it, you should be in a position to handle these things on your own. But in today's time and age, to be very honest with all of you, okay, I started off with a private setup with an individual practice, and now I am into a corporate hospital of my own. So what typically happens is, in a corporate setup, you have people available with you in and around you at a whisker. Okay, so if in case I require anybody for anything, I have absolutely no shame in calling people and making them sign and keeping them in the operation theater, so that post-operatively, it is 4 doctors going and speaking to 1 patient, or 4 relatives and 4 doctors are speaking, compared to 1 doctor speaking to 15 relatives. So if you start developing this, then what typically happens is the headache gets distributed between 5 people. This is just my experience, and I reserve the right to be wrong. I am a small man and I'm a young man. I'm not as experienced as majority of the senior colleagues which are present here. But this is my experience from my limited understanding, that if you have 4 or 5 people with you in the operation theater, and when people see that these guys have really worked hard in order to pull the patient out of a complication, the relatives and everybody usually calm down. And once they calm down, they become more receptive to listen to you as far as the negative implications of the disease are concerned. Because in bowel complications, you will face patients where there is a renal shutdown. You will face patients who has, developed a hospital-acquired infection, venti-acquired infection, urine output is not coming, something is going to go wrong. And your post-operative stay, post-fecal peritonitis is very, very unpredictable. So what we do here is that we tell everybody that the standard post-operative stay in the hospital is going to be 15 days. That is what we start with. We know it normally settles down in 6 to 10 days, but we tell 15 days. So everybody knows that for 15 days, we are not supposed to bother these guys as to why did you say 15th day, and now it is the 16th day. So we have to listen to that drama on the 16th day. Understanding? And I think if you are running a unit where you are handling fecal peritonitis as frequently as I do, then I think maintaining something like this, or maintaining or having something like this in your armamentarium might help you. With that, I conclude. I really thank all of you, Kalyan sir, Mala ma'am, Sujal bhai, Deven bhai, and everybody, and Ankur, for giving me this opportunity, and hopefully I shall be able to answer some questions.
Thank you, Jai bhai, for very, very, very insightful discussion. I think forum is open for all of us. I just wanted to know, you must be encountering lower anterior dissection syndrome also.
Yeah.
How do you counsel patient and how do you treat it?
Yeah, that's a great question. So one important thing for Lars, it's really tough to predict who will get Lars. Okay. But if there is a loss of bowel segment of more than 10 centimeters, especially for the long bowel, large bowel, the possibility of an unsettling Lars is pretty common. And this may continue for a prolonged period of time, because it is very difficult to understand how it will respond to and when it will respond to, and it is troublesome. So there is no question about that, isn't it? So what we normally try to do is we have a good addition inside our consent for women who are undergoing a segmental bowel resection of more than 15 centimeters. We tell them beforehand that this is going to happen, and usually they accept it very nicely. All the therapies which you try to give, right from nerve relaxation strategies to probiotics to intestinal motility reducing agents, I think a lot of problem these people face is not from the passage of heavy stool, I mean frequent stools. They face a lot of social discomfort when it comes to passage of frequent flatus. And that is something which they don't like. But I think, as you mentioned, it is very difficult for us to control.
So when you have multiple lesions, like how do you manage multiple lesions?
Yeah. I mean, see, if the lesions are less than 5 centimeters apart, then you will have to resect that entire segment together only, madam, because otherwise the anastomotic site will not hold through. But if in case you have two satellite lesions which are 15 centimeters apart, then it is better to resect them individually only.
So what is your cutoff for discoid and segmental?
As I mentioned, any lesion which is 1.5 centimeters in size and less than 15-20% in circumference of the bowel, disc will usually suffice. But if the lesion is larger, if the lesion is, let's say, 2.5 centimeters, sometimes you may not even get a complete disc. And in the bargain of just doing a disc, you should remember that that particular part of the disc should not undergo some stenosis at that anterolateral part where the disc has been taken. If that happens, then it is a big problem because it can cause post-surgical constipation in the long run to the patient. So that should not happen, ma'am.
Have you ever encountered in a small bowel the lesions?
So small bowel endometriosis and resection is something we will end up doing close to 4 cases to 6 cases in a month. The typical sites where small bowel is involved is where the ileum has gone and got stuck to the ovary, and appendix is also stuck there, and there is a nodule which is impinged on the ileum and the appendix both. So usually it is going to be something like that, but very rare to see isolated small bowel endometriosis in an otherwise normal pelvis. So that is pretty rare to see.
Yeah.
Dr. J, there's one question that has come from the delegates. They're asking, as far as bowel endometriosis is concerned, what is the role of preoperative endorectal MRI?
I don't do it. I don't think it is mandatory either. I mean, see, majority of the times what happens, I'll tell you. All these investigations will be done because patient is having chronic pelvic pain. Somebody will put a colonoscope and take a biopsy from a bulge on one of the sites in the rectum, and that's going to turn out to be endometriosis, and then somebody is going to tell you, oh, this is endometriosis, okay, go and get operated, something like that. That's the most common thing which happens. We don't recommend it because here we have a very, very good in-house ultrasound unit, as all of you are aware, and because we have an excellent ultrasound unit, we probably don't feel the need for an MRI.
Okay, is it okay in case of medical legal aspect? Won't you be questioned when you have some kind of a complication why an MRI wasn't done prior?
No. MRI also ultimately tells you that you need to correlate clinically. So as long as an investigation is then not the foolproof investigation or a 100% investigation, then 3D ultrasound and MRI both hold the same value in the court of law.
Jay, how are
If it
you
is an
going to
extra
diagnose small
Yes.
bowel lesion in
Yes, extra pelvic endometriosis MRI, yes.
of the pelvis?
I think two questions came together. Devan Bhai and Sujal Bhai both asked together.
Yes, I completely agree with him, Dr. Jay, that probably sonography is sufficient, but extra pelvic endometriosis MRI has some definite role. That is what I was telling.
Yeah. I mean, see, if there is an extra pelvic endometriosis, especially upper abdomen, then doing MRI is really, really important. But one thing we must understand is that if your hands get good at picking up almost everything on ultrasound, believe me, apart from thoracic endometriosis and diaphragmatic endometriosis, which ways ultrasound cannot pick up, you will be actually able to pinpoint and pick up most of it. That is just my personal submission, but that cannot be generalized. Yeah.
Yes. Devan, you were telling something, Dr. Devan?
No, same question, sir. I was asking same question, that what about the above pelvis? When in TVS, actually we are saying Vismay, he's doing very good ultrasound clips and all. Jay is doing very good in TVS and picking up nodules and almost 95 to 98% or 99%. But then what about upper abdomen? That's what
No,
I was.
upper abdomen, Devenbhai, if in case you are suspecting, it is better to do an MRI unless you have the type of ultrasound grooming, which we have. See, we have made mistakes in the past on ultrasound, and what we thought was endometriosis was just an angiolipoma.
Right.
What we thought was an angiolipoma was an endometriosis. So all these mistakes have happened by us in the past, and not that we regret those mistakes, but I think we learn from them. And when you end up learning from them, the next time you do the same characterization, no, your life will become much faster and much more easier for you as a surgeon and for somebody as a patient. So I think training is the deficit is training. The problem with ultrasound is it is not very reproducible. See, if Visma is trying to pick up something on ultrasound, he may pick up 5% better than what I may pick up. And maybe I may pick up 5% less than what Devenbhai may pick up. With MRI, what happens is that because the patient is in a static position, see, ultrasound is also dependent on dynamic movement in the pelvis, right? MRI is not dependent on that. MRI is a static examination. Patient has gone in the machine, one report will come. As long as the report comes in a particular manner, and if you are even a decent radiologist, you will be able to pick up what is adherent where. There is no question marks in that, isn't it?
Second is that MRI documentation remains with you for a very long time. And what happens, you can review it also. That is also an added advantage. And for patient counseling also sometimes to show it to the patient, because on sonography, it is sometimes, that is what I feel is difficult.
No, one for a tip for everybody who likes to do pelvic MRI, kindly do pelvic MRI suspecting endometriosis only and only with gel contrast. Yes. Do not end up doing pelvic endometriosis suspicion. Do not do an MRI pelvis. That has got nothing. You need to do an MRI pelvis if you want to do with gel contrast. Otherwise, you don't do it. As simple as that. So because you need a distended bowel on MRI, simple. You need a distended bowel and you need a contrast in the vagina to identify invasion. Otherwise, in a collapsed bowel, you are not going to be identifying an invasion. And most of the times you've seen MRI suggestive of a little adhesion here. And that little adhesion is actually a 4-centimeter nodule, So those can happen if gel contrast is not given to the patient.
So would like to add something about Sujal Bhai, what Sujal Bhai was saying, that he's absolutely right in saying that when ultrasound you do on your own, that's your own document. So when MRI or ultrasound is done by someone else and documented with a sign and stamp, it becomes a document that not only me see this is the report, which also suggestive of something like in endometriosis or so. Second thing, what Jai Bhai is saying that if you many times what consultant writes it is only MRI pelvis, then patient comes with report and there is nothing more. So if it is rectal and vaginal gel, and if it is good prepared bowel like Dulcolax you give and partially filled bladder, there are a few criteria which we follow. If there are hyperperistaltic bowel, we give injection Buscopan. We ask that radiologist to do ultrasound first and see, and then do MRI. There are a few points which if you follow, your MRI report becomes really good and you can pick up. Second thing is when you do MRI, you start reading MRI also with your radiologist friend, and also you can correlate between MRI and actually you are going to operate after that particular MRI. So that way you can you can learn, like we were discussing about.
So I would recommend to every viewer who is listening, there is a beautiful mobile phone app which is available called the DICOM app. Okay. And if you just download that on your phone, wherever anybody is getting an MRI done, the radiologist can simply push the code to your phone. Okay. And you will be able to access the MRI. The beauty starts after the surgery, where you tried to read an MRI before and you went wrong 50 to 70% in the first reading. Okay. And then if you do this over a prolonged period of time, let's say if you do this over a 1-year window, you will realize that your MRI reporting will become actually very good. You will be able to pinpoint small things in an MRI, and you will be able to counsel the patient much more than that radiologist report. This is my.
I agree, because
congratulate the Mayflower team here. The
Yes.
Mayflower team, they have sensitized radiologists so much that now pan Gujarat at least, the MRI reporting of endometriosis has gone to a different level. I must congratulate the whole team here. Sir
Yes, sir. I would also add, sir, because I have seen patients who come to, I am in Pune right now, but even in Delhi or Pune, wherever a patient has been seen by any one of us in Gujarat, the MRI reporting for endometriosis that has come to me has left me no doubts about the whole protocol that the Mayflower team has set up. In fact, they've also told us how, with Dr. Lakshman and Dr. Sanjay, they also told us how to read our own MRI. That was one of the major highlights of our training that we had in Mayflower. We would read the MRIs on our own, disregarding the report completely. So I
and
would say that, doing our own scans, not relying on the ultrasound finding of the radiologist and reading an MRI would form a very good basis to help our own preoperative evaluation of the patient.
So what is the tab?
Sujal,
So what is the tab?
Sujal, can I add something?
yes, please, sir.
Just to do the only simple MRI is not enough. You train the MRI center. In our center, I think every Saturday we do the clinical meeting. Those who we done the 7, 10, 15 cases in this week, try to make we do the interactions with our radiology MRI team people, and then it's updating what the Jay is telling. The training is the most important part. I not personally believe that 100% sonography is not conclusive, because in this era, I think we started with the transvaginal sonography. Even though we put the lot of gel in the rectum and we do the sonography and we do the transrectal sonography. At that time also we go for the colonoscopy in all the cases before 15 years. Now we stop it because it's very difficult to find out anything. But the most important part in our practice, we realize that MRI is considered to be one of the best tools. There is no question at all. There is a lot of limitations with the sonography because we have the dedicated 3D, 4D sonography unit. We try to make even though we every day we correlated, we do the sonography, we operated this case, and then we come in the conclusion. Majority time with the experience and with the so much training, I think up to the 90% we take the judgment related to pelvic endometriosis with the sonography. I think if you train the MRI people, MRI center, I think up to the 98% accuracy we get it. Small bowel endometriosis, one of the point I think I added it, due to the mobility of the small bowel, I think small bowel endometriosis ratio is very less. The majority time what we identify, the appendix is involved, cecum is involved, and some part of the ileum is involved. But the specific segmental endometriosis, I think it's the very rare entity. And that's why this is the peritoneal disease. I think this implant and invasive, and majority time those the affected organ, particularly on the right side of the mass, adherent with the appendix. In those cases, cecum is adherent, and I think the small bowel, maximum ileum is adherent related to this part. Second important point, I think, what the bowel, I think we start with the pig leg, exolytic, so many things. And I think the always, rather than the watery stool, I think hard stool is always better. In cases of the endometriosis, what we realized that we stopped the using of the pig leg since many years. After 2016, we just give the Dalcolex and Elprex. And I think we realized that I think this is the best thing to give it, because rather than the liquid stool, it's contaminated more in abdomen, and the solid stool is always better. And I think pig leg, it also creates a lot of electrolyte imbalance and everything. So accordingly, I think just you give the good Dalcolex and prepare the bowel. Maximum you give the soft diet for the 1 day patient. And second, even though in the any bowel resection or go for the discoid, I think Dalcolex is more than enough for that.
So thank you so much, sir. I think it has been a very extensive discussion, and it was a very nice presentation by Dr. Jay. In fact, rather than having a presentation, the discussion aspect of it was, I think, would have been a very welcome aspect of this particular talk. So I think with this, we wind up with this particular session and move on to the next one. Thank you so much, Sanjay Patel, sir. Thank you so much, our chairperson, Dr. Sujal Munshi, and also Dr. Jay Mehta, for your wonderful discussion on this particular aspect of bowel endometriosis. So I would like to now move on to the next session and would like to welcome our young youth council member, Dr. Balaji, to introduce our chairperson, Dr. Nisha Kapoor.
Thank you, madam. We are moving towards the last session, which is on the urinary tract endometriosis, safe techniques for ureter dissection and the urinary bladder safety. And for that, we have none other than Deven Bhai, who is a very renowned endoscopic and endometriosis specialist. And for this session, we have a chairperson, Dr. Nisha Kapoor ma'am. Madam is a professor and she has a vast experience of 35 years. She is a postgraduate teacher for 20 years, and Madam is a director and professor, head of the department at minimal invasive surgery and robotic surgery at Maringo Asia Hospital, Faridabad. She's the president of Haryana Association of Obstetrics and Gynecological Society. And Madam is an all-rounder. She is a very renowned obstetrician for high risk and critical obstetrics. She is an infertility specialist as well.
Thank you, sir.
Yeah.
Thank you.
Welcome, madam.
Thank you. So our next session is again very important session, very important part of the deep infiltrating endometriosis, that is urinary tract endometriosis. We all understand that this particular endometriosis, especially the ureter, that has got a very subtle presentation, and early diagnosis is so very important to save the kidney. And while handling the endometriosis, again, the dissection has to be, very, very meticulous and very careful. And on this topic, we have none other than Dr. Devan Jogal to speak on this topic. We all know he's a very fine. He has got, so many accolades to his credit. You can all visualize that. But I have seen him in my own OT during the last Haryana chapter IAG conference, and I have felt mesmerized seeing his wonderful dissection of deep infiltrating endometriosis. So over to you, Dr. Devan Jogal. We are waiting for the mesmerizing videos and your wonderful talk.
Thank you, ma'am. Thank you very much. And I would like to thank IAG for giving me such a nice opportunity. It is always good to present endometriosis when our guru of endometriosis, Dr. Sanjay Patel sir, is with us. So thank you very much. And I'm sharing my screen. My topic, which was given to me, is urinary tract endometriosis. And as Dr. Jay rightly said, that we maybe, I'm sharing my screen, just a minute. We can go for the discussion as well, as and when you feel like. This is I'm just 2 or 3 clips and little bit of literature which we are going to discuss. So urinary tract endometriosis, we all know that affects approximately 10% of women of childbearing age group, from which endometriotic implants, if we see, there may be implants on uterus, vagina, ovaries, fallopian tube, digestive system like rectum, sigmoid, and cecum, ileum, and urinary tract, which is topic today, so bladder and ureters. Actually, a part of sight, what should be the ultimate goal in doing surgery for per se in entire endometriosis? If we say the goal of the surgery should be restoration of normal anatomy, removal of endometriotic lesion, prevention of adhesions, and for bleeding minimizes use of cautery and sutures to minimize bleeding. Any kind of endometriosis surgery, there are standard steps. So it is not like endometriosis surgery is rocket science nowadays. So anything, if you have urinary tract endometriosis, you have bowel endometriosis, you have in general grade for endometriosis, DIE, there are standard steps which we follow. So what are those standard steps? So first is always edesholysis and restoration of anatomy. Second step is sigmoid colon mobilization. Third step is always endometriotic approach, which is ureterolysis, which I'm going to show in my clip also. Fourth step, this we are talking about conservative surgery. So it is ovarian cystectomy, if at all there is a chocolate cyst. Fifth step would be a pararectal space dissection. Sixth step, if it is involved, then rectal shaving or SOS ball resection and anastomosis and clearance of all endometriotic nodules. Now comes so on and on, like if bladder is involved or ureter involved or so on. So this was the case of previously operated case of endometriosis, where there was a nodule and they missed this nodule. Ultimately, patient started having urinary complaints, and we went in, and this was the picture on cystoscopy. So you can see here on cystoscopy, when we go in, we follow standard protocol. So on cystoscopy, this is the one side ureter, a ureteric opening, which we see. That's the ureteric opening from the one side. We see entire mucosa, and this you can see the endometriotic nodule, which is inside the bladder. We recognize this nodule. Thereafter, after recognizing it, we have put a grasper inside to locate this nodule. Exact location of this nodule should be identified, because when you go laparoscopically in, and that time identification of this nodule is very important. So this is post-hysterectomy patient. You can see bladder dissection. You can see bladder, we are mobilizing it. Here comes role of traction and counter traction, where my assistant is giving counter traction. This is bladder dissection, in which I'm using a bowel grasper on the left side and ultrasonic energy from the middle port. Counter traction or counter, support is been given by my assistant. Thereafter, identification of the bladder nodule exactly from the bladder side was done. Now, after identifying bladder and bladder wall dissection, we are continuing. We are separating bladder peritoneum. Amount of puckering and amount of adhesion you can see there. These are the very fine and small steps which we follow, because we don't want to make a cystotomy at the site where it is not required. Okay, so this you can see here. Just a minute. Yeah. So after doing this much of dissection, now important point is bleeding also, because many people, they say that we have to use cold scissor here. I completely agree if someone is comfortable, but then for me it is not very much. I'm not very much comfortable with cold scissors, because it causes bleeding, and whenever there is a bleeding, you get very less idea about the plane, and if you do not get proper plane, then doing dissection would be very difficult. As it is, bladder dissection is always difficult in post-hysterectomy patient, because of the orientation and because of the amount of fibrosis. So this, we are putting a vaginal tube from the vaginal side, so that we can identify bladder. After doing this much of dissection, now we are going for cystotomy. Now we have marked our lesion, and we are now going around that lesion. You can see here, after marking that lesion, that's elective cystotomy with what we are doing. I do not prefer to make a big incision on the bladder that usually you must have seen. Usually neurosurgeon, what they do is they make a big nick. If they put a big nick inside the bladder to see inside the bladder, or to locate disease, or usually I do not prefer. I usually prefer to locate whatever is required, and what incision actually required, that much incision I prefer to give. So this is bladder, you can see, and the nodule which is been held cystoscopically by grasper. This is surrounding dissection, what we are doing right now. And after that much of dissection, we are going to give traction, and we are going to now remove cystoscope. We'll make sure that no endometriotic nodule remains inside. And after that, we are going to suture it for bladder, I usually prefer to use Vicryl. We can use VLOC as well, but that day when we operated, that was operated not in my center. So we did not have VLOC there, so we used Vicryl. And with routine art of suturing, what you are doing for what suturing, you can go ahead suturing bladder as well. And usually single layer is enough. We don't believe in putting a methylene blue and inflate it with the methylene blue or with water to see watertight suturing. That is, I personally think that will make your suture line weak. So we don't do that. Definitely after that, we keep Foley's for the I usually prefer to keep it for 10 to 14 days. That means for 2 weeks. And usually it is enough. And usually in electively doing such kind of surgery, there is no problem at all. So patient is doing well. And that's the suturing. And this is the end part of the suturing. Okay. So that was about the bladder. That was a safety technique, how we can deal with bladder. Now, as we are talking about endometriosis and urological things, so after bladder comes ureter. In this video, I'm going to show you the exact technique of doing ureterolysis in such kind of cases where there is minimum damage to the ureter and maximum effect what you want exactly in this kind of surgery. Because there are, if you see, there are many cases of avascular necrosis which we come across, and it is very dangerous. So that's why knowing how to do ureterolysis is very important. You can see here, in this case, I'm remaining on the top of the ureter. You can see I'm using ultrasonic energy, giving traction and counter traction. I'm giving traction from my side, and counter traction is being given by my assistant. You can notice that we are not going to damage any vascularity of the ureter. We remain on the top of the ureter without damaging any vascularity of the ureter, not going to medial or lateral side of the ureter without any reason. And easily and gently we can go in, use diversion force of your ultrasonic energy to dissect. And slowly and steadily we reach up till the ureter tunnel, where ureter turns in and goes inside the tunnel. And you can see at the end, this is the picture. It takes very less time. If you follow the standard technique, believe me, it takes very less time and very less efforts, okay, of ureterolysis. People, they are afraid of doing ureterolysis because first they afraid of damaging it, second because of bleeding. So if you follow the standard techniques, there are very less chances that you will have bleeding, and there are very less chances that you will have ureteric injury. Okay, so this is standard, just a small clip, a standard ureterolysis, how it looks like. Now there is one more clip which I'm going to show you where ureter is completely involved extrinsically, and it is the endometriotic nodules and endometriotic area encasing that the ureter goes right from in between that particular area, and we are dissecting. You can see here that's the ureter. There are ureteric nodule from the extrinsic area, so above the ureter. After doing dissection, you can see this is the area where now I have to use scissors. What we prefer is, as far as possible, if you can go away with shaving, be it a bowel, be it a ureter, we always prefer to go with shaving and suturing if at all it gets damaged. In case of ureter, such kind of surgery, if we do, we always prefer to put DJ and keep it there for 40 to 45 days. Now this becomes quite difficult if you don't have person who can give counter traction. Okay, so you can see here my assistant from right side is giving a traction in attempt of making ureter a nodule free. You have to go for shaving. There is no question about it. Should not be leaving behind any minor amount of nodule, even if ureter gets, little bit of because of your seizure and ureter, even if there is injury, you can always suture it. So that is not an issue. This is exactly on the top of the ureter, and you can see the serosal layer or upper layer of the ureter, which we are shaving it off. And you can see amount of thickness and how hard it is. Even with my scissors, I'm facing difficulties, shaving it or taking it out. So this is again ureter, which we made free after ureterolysis and dissection. So this is complete ureter. It was initially, there was a hydroureter, but then after surgery, we can see that it has reduced little bit and it completely reduced after a few days of surgery. So that is for presentation point of view. That is all from my side, because safety wise, I think we can discuss a few points in question answer session. So I'm stopping my screen. Yeah, sure. And yes,
Thank you,
now
Dr. Devan. It was a very illustrative talk and very beautiful videos of dissection of the bladder and the ureter, and a very targeted dissection, very conservative but thorough dissection. So that was the good part of it. So I have some questions that how do we suspect intrinsic ureteric endometriosis in cases where you find a hard nodule encircling? Do you do ureteroscopy in all such cases? And what are your criteria for doing resection and anastomosis for ureteric endometriosis?
Madam, actually, I'll answer first about resection and anastomosis or reimplantation. So we follow standard protocol whenever it comes to lower 1/3 of the ureter, involvement of lower 1/3 of the ureter anywhere, in any cases. We always prefer reimplantation, which gives you best result. Problem in resection and anastomosis is you don't realize while doing it, but then later on patient will face problem. One most important problem is stricture, which will not set in, immediately after 1 month or 2 months. It will set in after 6 months or 1 year or so, and you will have to follow that patient up. So that's the major problem. Second is in that ureter where resection and anastomosis is been performed, chances of stone getting stuck because of the narrowing of that ureter are more. So such kind of patient, they will suffer more. I live in Kutch area, which is a desert place, and we have so many cases of stone here in my area. So that's why we are very much careful in such kind of patients, because most of the patient, they have stone. Most of the people, they have stone here in this area because of the area wise. So that's the thing, that if it is lower 1/3 of the ureter, it is always better to go for the reimplantation if there is involvement, and not resection and anastomosis. If it is mid or upper, then resection and anastomosis is the better choice. But then you have to follow that patient up after, after Foley's removal, after DJ removal, then after 2 months, 3 months, ultrasound for hydroureter hydronephrosis, that you have to carry on and you have to follow that patient up. Second thing is, I think it is very difficult to identify or to diagnose intrinsic involvement of the ureter, because it is very difficult. You cannot diagnose it without doing ureteroscopy. Ureteroscopy, usually we do not advise randomly in every patient. But then if patient is having suspicion, where a patient is having hematuria, when patient is having problem while passing urine, and when we feel like doing cystoscopy is must, that time with great suspicion we keep urologist with us, and we always try to combine this procedure, cystoscopy as well as ureteroscopy, because cystoscopy is something which we do day in and day out. So it is for which we don't require a urosurgeon. But then when it comes to ureteroscopy, it is definitely we combine both the procedures and we invite urologists to do ureteroscopy to diagnose. But then it is very difficult to even suspect that patient has intrinsic involvement.
Okay. Another thing in my mind was, do you ever use ICG for any advantage in any of your cases? I mean, do you find it advantageous, and in what cases would you find it, to your benefit,
I
while
see. As
saving
of
the.
now, actually, I don't have experience using it because I'm not using it, and I have 3D. So for using ICG in cases where 4K 3D and all, the mode has to be available there. So that actually I don't have. That is the one reason. Second, I don't have experience of using it. But then promising studies are coming up suggesting that use of ICG in future days are going to go up and up, and ICG usually in cases of C endometrium and for sentinel lymph node people, they are using it very very efficiently. So I don't have personal experience of using it, but yes, future is very bright, I think, for ICG.
Okay. Thank you so much for the lovely answers. We have, I'm perfectly convinced by, on my queries. And let's have some queries from other faculty as well as any queries, Dr. Ankur Shah from delegates.
Nothing, ma'am. Probably just for the benefit of the delegates, ma'am, I thought since Devin sir has talked about DJ stenting, a general question that I would like to ask is, would you like to do DJ stenting before you would want to do ureterolysis or after? Because
Uh, I'll answer and I'll tell you what I personally do and what I personally think. I think degestenting or ureteric stenting before surgery makes surgery difficult for me personally, because pliability of the ureter is gone and continuously rigid ureter will be staying there only in between your dissection point. So I usually do not prefer to go for the preoperative stenting in cases of endometriosis. Yes, I would prefer going for DJ stenting or ureteric stenting when there is a large ovarian mass, when there is a large, masses or so, where identification of the ureter becomes difficult.
yes.
So in open surgeries where I have to go for laparotomies, yes, I would prefer going for because as we say that we learn by our mistakes. So I have made so many mistakes in my life also, and I have learned that in laparotomy, if I am going not for endometriosis, because laparotomy we don't do for endometriosis, but for some other reason, if we are going for laparotomy and difficult case, yes, I do prefer going for the degescending or ureteric stenting. But in endometriosis case where laparoscopy currently I'm going, I do not prefer. Rather, I prefer even single percentage of doubt I would prefer doing it post-operatively, keeping DJ there. Let's say let it be there for 15-20 days or so in cases where you have just a small doubt or so, but not pre-operatively.
Devin, congratulations for the excellent talk. Great teacher, great academic surgeon. I think one point I narrated for the ureterolysis. I think majority people jump for the direct ureteric implantation. What you narrated is absolutely right. In our center, 10 patients came for the presented with the hydronephrosis, hydroureter. Out of 10, one patient we go for the ureteric implant. Those cases of intrinsic involvement. And during the time, if you dissect the ureter, just you palpate it. It's the hard one, I think. And it's majority time, it's invades inside the muscular, it's break, it's also its own. And sometimes you find out the hourglass structure of the ureter. In those cases, you go for the end-to-end anastomosis or ureteric implantation. But majority cases, you try to do the ureterolysis first. You try to make the excise the ureteric nodule over it. And even though in the hourglass structure, try to make do the stenting. And I think as far as possible, try to make avoid the ureteric implantations or ureteric anastomosis. This is the one of the, you give the take-home message for the audience. Thank you. Thank you, Devin.
Thank you, Patel sir, for your wonderful inputs. So, any other queries or any other comments from Dr. Mala?
So I think it has been a very excellent discussion. I think most of the things have been really clarified and also discussed. So Do we have anything from the audience also?
Ma'am, Dr. Aruna Tante is there in the audience. Ma'am, good evening. Just one thing that she's put up is if you find hydroureter preoperatively, in that case, what would you do? Ma'am says, is a DJ stenting required in that case?
Yes, sir. In cases of hydroureter, you can go for DJ stenting preoperatively, but still in cases of hydroureter, still my preference would be going for DJ stenting post-operatively, not preoperatively. But then it depends on the category of hydroureter also. If there is a small amount of hydroureter and not mega ureter, okay, then definitely good. But then the problem is if there is a large category of hydroureter, putting DJ would be difficult. That is one, because chances of perforating it would be high. So it is always better to put laparoscope in first, then under guidance you put DJ stenting, do DJ stenting, and then you start surgery. Even if you want to put DJ stenting before surgery, like before starting surgery.
One of the important point for the ureterolysis in endometriosis, you find out the pseudocyst.
Yes.
And if any patient presented with the hydronephrosis, try to make the enter in the pseudocyst and try to make the dissect parallel to the pseudocyst. Majority time you reach up to the obstructor site. This is the main area is involved in the parametrium. It's the transverse parametrium, and once you crossing the uterine artery. So in such cases, I think you go for the deroofing of the ureter with the try to make the sacrifice the uterine artery, and then you dissect parallel to the uterine, right? Majority time you find out the stricture area, and then you, I think, cut with the scissor. And lastly, never put the before surgery you try to make the do the stenting, because there is a higher risk of perforation in such kind of the cases. Absolutely, Devan, you are absolutely right.
Right. So the take-home message is that no pre-operative stenting. Most of the times, whenever we have to do it is after the surgery. So it will make the surgery difficult if we do the pre-op. Thanks for the take-home messages, Dr. Patel sir and Dr. Devan sir.
For the ICG dye, so ICG dye, and then doing an erythrolysis.
That we have discussed with Madam also. Madam also asked the same question, and answer is actually I do not have experience of using ICG for that particular reason, and that's why. But then I think ICG is future, not future. It is already present, and in future role of ICG is going to increase, especially in cases of oncosurgeries and in endometriosis as well. But then I don't I personally don't prefer using ICG in endometriosis.
So I think we are on time also, no? Most of the discussion has, anything else you want to ask?
I think we are done with the queries, and thank you, Dr. Madha, for making me a part of the webinar. Thank you, Dr. Kalyan, Dr. Sujan, and Dr. Sejal Naik for giving me this opportunity. It was a real pleasure. Thank you.
Yeah. So I think I like to thank all our faculty and also the chairpersons who've been part of this Scope and Trocar series. I think this series is in fact doing quite well because we are staying focused on one particular topic, pertinent topic to our clinical practice, which is most of the time not much discussed. And we are also having very good faculty for this program. So I would also like to thank IAG for this initiative, and also now request our Sujal Munshi Bhai to give the vote of thanks and wind up the session. And before we conclude, I will also like to thank the Shield Pharma for their academic partnership with IAG for this entire series. Over to you, Dr. Sujal Munshi.
On behalf of IAG, I would like to thank you, Mala Madam, for organizing this wonderful event, Dr. Ankur, Dr. Balaji for conducting it very well. We had very good speakers, Sanjay Patel sir for being personally here and enlightening us, Dr. Jay Mehta, Dr. Deven. They are doing wonderful work, and they shared some of the very, very, very good insights. So thank you very much, and thank you, Dr. Kalyan sir, for this initiative, and whole team IAG. Let this work continue. Thank you.
So thank you. So thank you, everyone. See you in the next month. Scope and Trocar series. Bye.
Thank you. Bye.
Bye-bye.
Thank you, sir. Thank you, ma'am.